Hi, I'm Dr. Scholz. Let's talk about prostate cancer. We've been through a lot of these videos, and we've been following a format of going through each of the 15 stages of prostate cancer. Today we're going to cover high royal, which is the 15th stage. For those of you that aren't familiar with the PCRI color system for staging, high royal would be considered advanced prostate cancer. Advanced prostate cancer falls into three broad categories. We call them low, basic, and high royal. High royal means more than 5 metastases visible on a scan, and at least one of those spots has to be outside of the pelvic region. Pelvic region is right around where the prostate is. So high royal means something spread outside there and more than 5 spots. The treatment approach for high royal is to be aggressive. When we're talking about the most advanced stage of prostate cancer, we're talking about when this condition starts to become life-threatening. There's a couple basic principles. This is an overview of high royal. We could probably do 10 videos on high royal and not run out of different topics. And we will come back at some point and talk about different treatments in more detail. This is just an introduction to make sure that you have an overview and you aren't missing something obvious. So one of the principles is that we have multiple life-prolonging therapies now. Treatments that have been approved by the FDA that are proven to make people live longer. It's a terrible shame if people don't get exposure to each and every one of these treatments to optimize longevity, which is the goal of effective treatment. We also want to give them as early as possible. Over and over, studies show that the same treatment given at an earlier stage, I don't mean before high royal, but as you can imagine, there's earlier stages of high royal and more advanced stages of high royal. When you give effective treatments at an earlier stage of high royal, it enhances longevity to a very significant degree. It makes sense. The treatment's the same, but at an earlier stage, there's less cancer to fight, and the disease is more vulnerable to the therapy. So in a perfect world, if all these different treatments had no side effects whatsoever, you'd give them all simultaneously at the first stage of entering into high royal. That would give you the best overall anti-cancer effect. Practically speaking, that's not possible. These medicines have side effects. Sometimes they can't be given simultaneously. And so there's a sort of a pathway or a sequence that people often fall into when selecting therapy for high royal. Usually people start with less toxic treatments and then subsequently implement treatments that have more side effects down the line. The thinking for that, of course, is that quality of life needs to be preserved at all costs as well. So we're balancing between preserving quality of life and optimizing longevity. Close monitoring of therapeutic results is essential to be able to know when a shift in treatment needs to occur. Everyone sort of knows what these things are: PSA response, changes on scans, new spots on scans, high rising PSAs or PSAs that fail to continue declining are all signs that the treatment's effect are running out of gas and it may be time for a change. Those principles, again, could be the subject of a video in and of themselves, and the whole idea being is that if the PSA stops dropping or if new spots are appearing on a scan, you need to be talking to your doctor about a change in therapy. Since this is just an introduction, I want to briefly go through the different FDA-approved medicines for high royal in the sequence of what one would normally think about using them. To start off with, not everyone with metastatic disease has developed resistance to Lupron, so-called hormone resistance or androgen resistance. That doesn't mean that people who are starting Lupron for the first time shouldn't do additional therapy at the same time. Lupron alone is effective, but not as effective as using things in combination. So typically people will initiate both Lupron plus a second generation medication that blocks hormones, i.e. testosterone, more effectively, medicines such as Xtandi or Zytiga. So it's very common for people who are either Lupron resistant or people who can still respond to Lupron to be treated with a combination of Lupron plus Xtandi or Zytiga. And I use those two medicines more or less interchangeably. There's pros and cons with each one, but they seem to have similar effectiveness. If those medicines stop working, the next tier of therapy is to think about some sort of immune therapy, such as Provenge, which is FDA approved, to treat men with prostate cancer. Provenge is a very convenient, easy to administer treatment that is given over a 6-week period. Immune cells from your body are removed in sort of a dialysis type procedure. They're shipped off to Seal Beach, California, and the cells are activated to fight prostate cancer. Subsequently, they are then reinfused into the body to fight the disease. Provenge has been controversial for a number of reasons. One is that we typically don't see sharp PSA declines after Provenge. This doesn't mean that it's not working. Studies clearly show prolonged survival. Some of the early studies, which were done in very advanced disease, showed sort of a modest improvement in survival of 3 to 4 months. Subsequent analyses of those studies show that men that get started in a more timely fashion can prolong their lives by well over a year. Provenge is given over such a short time period, it's easy then to quickly move on to some other form of therapy. The next tier of treatment would be something like either chemotherapy with Taxotere or Jevtana, or an injectable form of radium called Xofigo. Both of these medicines have been shown to prolong life. We'll tend to lean towards Xofigo as long as people don't have terribly rapidly advancing disease, because the side effects are less. Xofigo is given as a simple once-a-month injection. Sometimes it'll cause a little nausea, sometimes a little diarrhea, but generally very well tolerated. After that therapy has been administered, it's logical to consider some of the standard chemotherapies that have been around now for 15 years, Taxotere and Jevtana. Typically, Taxotere is started first. This is a medicine that's infused intravenously every 3 weeks. It's given with supportive medications to boost the immune system, medicines such as Neulasta, Neupogen, and other types of agents. And treatment is monitored because PSA declines are expected to occur. And if they are not occurring, then these medicines are stopped early. There's been some studies recently suggesting that Jevtana, a medicine very similar to Taxotere, has fewer side effects than Taxotere, and some people like to switch over to the Jevtana to try and improve quality of life. These are the standard things that are used for high royal. What if all these medicines have been used up? What's the next step? Well, typically people start thinking about clinical trials. And this is a vast and rapidly changing landscape. One thing that has come to attention in the last year or so is a new injectable form of radioactive medicine called lutetium-177. Clinical trials are running all across the country, and responses have been remarkably good with relatively few side effects. So if you're facing a situation where a clinical trial is being proposed, look into lutetium-177 injections. When a person is in the high royal category, he's in a fight. These medicines that we've been talking about can cause fatigue and other side effects. It's important to maintain fitness throughout. I'm often asked about diet as well, and it does appear that modest diets, vegetarian diets, do have an inhibitory effect on the cancer's growth. The simplistic view would be if you don't feed the cancer well, it doesn't grow as well. So staying away from the typical American diet, the hamburgers and the high fatty foods, the animal products, is probably beneficial. Lastly, long-term hormone blockade leaches calcium out of the bones and can cause osteoporosis. There's a number of medicines that are available to counteract that. A popular one is called Xgeva, Xgeva, an injection that's traditionally been given once a month. It's very effective. The problem is in cumulative doses, it can have issues related to the teeth or to the jawbone. And many physicians have backed off from the standard format of monthly injections and are using it a little less frequently to reduce this risk. I hope this has been helpful for you to just introduce you to the broad field of advanced prostate cancer. We're going to revisit a lot of these different medications in more detail and try and expound upon the advantages and disadvantages of each one.